Recording now, and we are going to be recording this presentation. So for anyone who registered, they will be able to receive this recording after the session. So I just wanted again to welcome everyone. I'm so glad to see so many of you here today on what I would consider, I think we'd all consider, especially once you hear about these resources, these are important resources that everyone should know about in New Hampshire, every business, etc. So with that, just a few guidelines. I'm Karen Morton Clark. I'm going to be your host today. I'm one of the recovery advisors for the Governor's Recovery Friendly Workplace Initiative, which is also administered by our great partners at Granite United Way. Just a couple of guidelines, as I mentioned. If you have not yet muted yourselves, it would be great if you would do that, please, as it can be very distracting to whoever is presenting to have background noise that I'm sure would be unintentional, but at any rate, just a reminder on that. We will be recording this presentation, as I mentioned. However, we'll probably have the recording shut off just before the end if there happen to be other questions that you wouldn't want on recording. We will go through the entire presentation covering 988, the doorways, and 211, as well as the rapid response. And we'll be doing all of that before we open it up to questions. I do have an advanced, I'm sorry, I don't have an advanced question for this session. But during the session, you are welcome to put your questions in chat. I do have members of our team are monitoring chat and so forth, and maybe communicating with you throughout the presentation as I will be facilitating. So with that, I would like to introduce to you our three key presenters today. First is Jenny O'Higgins. She is a senior policy analyst with the Department of Health and Human Services. Kara Washam is a behavioral health liaison with New Hampshire Rapid Response Access Point. And Melina Burton is the director of 211 New Hampshire, also an initiative of Granite United Way. So with that, we're just going to get started. And Jenny, I'll turn it right over to you.
All right, sounds good. So I'm just going to share my screen and we're going to run through some slides if I can get it to work properly.
I'm seeing your screen, Jenny. Once you're in slide mode, we should be good. Oh, no, it disappeared.
I just thought I had to do this to get it to go to the beginning, but I'm not sure.
That's all right.
There we go. I just couldn't see the little bar when I'm sharing screen in order to move it along. So so we're just going to talk through our behavioral health crisis system in New Hampshire in sort of its current state, as well as our future vision for where that's going. And happy to take a bunch of questions and make sure that everybody feels as though they have a good understanding of where New Hampshire's at. So essentially, this is just the background drivers for why we've made such a big transformation in the state of New Hampshire. So it's really a whole mix of things. So the Department of Health and Human Services had created a 10-year mental health plan with all of our partners, community members, people with lived experience, and really significant research and looking at what are the gaps in our delivery system in the state of New Hampshire and what are the recommendations for New Hampshire's model of where we could go across mental health broadly. The 10-year mental health plan called for both a centralized access point, so one statewide entry, in order to have phone, text, and chat that people could utilize easily and be able to access throughout the whole state and across the lifespan. The 10-year mental health plan also called for enhanced regional delivery across the lifespan again, and the Children's System of Care Plan and Senate Bill 14 that was passed in 2019 required statewide mobile crisis services be available for children and youth. And our model is all really based on the Crisis Now model, which is national, and the federal government making some changes to their centralized access line, the suicide prevention lifeline really expanding to be more around behavioral health and really about the crisis as defined by the individual. So being able to call for any reason and kind of get upstream in prevention. The Governor's Commission on Alcohol and Other Drugs also has a strategic plan. And it also called for a one-stop shop type model. So that's the idea of a centralized access point, as well as access to mobile crisis teams. And mobile crisis teams are really a model where a peer and a clinician could come to you in the community and give people services that they need when and where they need them. And so all of this has been happening in New Hampshire, as you can see, for a number of years, right? So having conversations about where we need to go, and you'll kind of see 2019 as the time that there was the mental health plan, there was the system of care bill, there was the new, strategic plan for the governor's commission. So this thinking has been going on for a number of years in New Hampshire, looking at how can we build a crisis response that is not age specific, right? So we used to have mobile crisis teams, in 3 areas of the state, in Nashua, Manchester, and Concord, and they were serving adults. And so we were looking at our system and we're thinking, geographically, having different services available is really tough. Age-wise, having different services available is really tough. And when people are in crisis, they can't navigate a system where they have to know this one's for adults and this one's for kids and this one's for substance use and this one's for mental health and this one's available in Grafton County, but this one's only in Hillsborough County, right? It's too much. So how do we take our whole system and try to make it really accessible and try to make sure that you don't need to know if you have a diagnosis, what your diagnosis is, if you have, all of these different things, really that the approach would be person-centered and whole person health, and be able to have the access point itself, be able to access all different types of services, have it really be across the lifespan, across all geographic regions. And I think the other really big thing is around the crisis as defined by the individual. So not that you call, that we're telling you to call this line for this thing and this other line for this other thing. So that's sort of some of the big thinking. The other really big change, I think, philosophically, is being very recovery oriented, including peer voices at every level of the planning and every level of our crisis system, having folks with lived experience inform the system, and showing up for people in a way that works for them. So essentially 2019 is when we launched the doorways, and then I will go in and talking a little bit about rapid response and 988 and what those are. I'm just showing you a bit of a timeline in New Hampshire, and then showing you that with no date here, that the vision for this crisis services system is that there's seamless integration. So while I talk through the doorways, it's going to be substance use disorder specific or substance misuse specific. And then when you talk about rapid response, it's actually really opened up to be, either or, co-occurring disorder, substance use, mental health, and or both, and or neither diagnoses, but call because you're feeling overwhelmed, right? And that's similar with 988 as well, that you'll hear that 988 nationally, that change was the suicide prevention lifeline, and is really getting more upstream in its change and just access to a broader serviceable population. And so that's the direction that crisis care has been going anyway. And New Hampshire will be making those changes eventually too. So I'm giving you a today state at the same time that I'm trying to talk through a future vision state. So initially, the purpose, what happened to stand up the doorways in New Hampshire is that New Hampshire received a really significant amount of money through the state opioid response grant. So that's a Substance Abuse and Mental Health Services Administration, SAMHSA, has large grants to states. The funding is actually based on a federal formula. And because New Hampshire had such high overdose fatality rates comparatively with our population specifically, the state was awarded $28 million a year in 2-year increments. We're now on our 3rd iteration of the state opioid response grant. And the major goals around that grant were decreasing fatality, increasing access to medications for substance use disorder, and distributing naloxone. Those were some 3 really big overarching goals around the state opioid response. And the way that New Hampshire approached that big first iteration of that grant was to say, when we look across what's going on with substance use disorder in our state, access was the biggest problem. And so we needed to figure out how to make access easy and low barrier. right? And so that was the biggest goal in that very first iteration of state opioid response. It was, how do we build off of the existing sort of prevention, treatment, and recovery landscape, but just make it so easy to take the first step? And so the doorways were created, and there's 9 doorways throughout the state of New Hampshire, and they are meant to be, connected to hospital systems and geographically located so that folks have access to them, no matter where in the state that they live. And the way that New Hampshire also wanted to set things up was, again, the visioning for what New Hampshire would have for a behavioral health crisis system was to have one easy phone number, centralized access, and access across all these geographic regions. So the doorway is really like the first iteration of that, where we partnered with Granite United Way to say, people already know 211. 211 has this whole host of other social services and supports access to these things. So what if they called 211 instead of having to know 9 different phone numbers and figuring out which region they lived in and which doorway to call? So that was sort of the first iteration of, what is it going to look like if we just had one number to go to? And of course, we've now a little bit overcomplicated it because we have these other secondary and tertiary systems of rapid response and 988 that I'm going to talk about. But we are, again, sort of moving towards making sure those are all very, very much integrated in the future. So if you call 211, that's sort of the easiest first step, is to call 211, and 211 will tell you where your doorway is and directly do a warm handoff. So you don't need to know which of the doorways to call. Rather, you could start there, and then they'll do a warm handoff to the doorway, and the doorway is connected to community providers. So the doorway is that first step, and the doorway then can do I don't know the doorway slides as well as the rapid response slides. So I'm just getting ahead of myself, and then the slides are kind of catching up to what I've just said. So it's available 24/7. You can call and get information and a referral. And that warm transfer to the doorway. And then the doorway itself can do, make sure that they talk through with you what your needs are. They can do assessments, and they can connect you to linkage and referrals. So you'll see this is kind of the piece where you can get a clinical evaluation, you can get, screening and crisis stabilization, facilitated referrals to treatment, recovery supports, recovery housing. They also have flexible spending funds, and so they're able to sometimes to help people reduce barriers by meeting their unmet needs. And so that can be huge because there's a lot of barriers to getting care. And another really big piece of what the doorway does is our community naloxone distribution. So there really are the access to naloxone throughout the state. So after you have, been able to talk to or go to your doorway, and you, have been able to get crisis stabilization supports in that moment, or done a clinical evaluation, the big next step after somebody in the doorway has been able to sit with you and spend some time figuring out what are the needs. The next piece is, what is the linkage and connection directly to support services? What's that referral look like? And so sometimes that referral is directly to substance use continuum, right? That you needed for whoever was calling, family or the person, needed supports for prevention, treatment, recovery of substance use. Sometimes it's actually mental health supports as primary. Sometimes it's that you needed a connection to primary care or housing. And so that all of that is a part of doorway services. And then these are your doorways by region. But again, by calling 211, it makes it so that you don't have to know which doorway is right for you. That makes it the easiest step, the first step, the easiest step for people by having the 211 connection. But what's great for businesses is that you could, if you have a doorway, in your region of where your business is located, you could connect with them for that naloxone distribution, to help you work on any policies for employees and things like that. So it's great to make those direct connections and build relationships with your doorway because they have such wonderful resources. The one other thing I'll mention before I move on is just after hours. So when you call 211, it's 24/7. And the doorways themselves are open regular business hours. So the doorways are open Monday through Friday from 8 to 5. But we also have an after hours clinical connection. So you can be warm transferred to the after hours clinician at Dartmouth, and you would still be able to get an evaluation, or you would still be able to access the flexible funding or the connection to care overnight, including respite. So the other piece I just didn't mention there is that the state opioid response grant also covers respite, which is when someone is in need of treatment services and unable to get to treatment services immediately and doesn't have a safe place to stay. They often access respite where they're able to have a safe place to stay and a connection to treatment. And the after hours care can also make that connection.
Jenny, just a quick question here, because I know I've heard this before, but my understanding is that an individual can choose to go to whatever doorway they wish. So even though they may live in that particular area, if they want to go to another doorway, they are able to do that. Can you just confirm that?
Everything to do with all of our crisis system is all person-centered. So everything should be through the choice of the individual.
Perfect, thanks.
Yeah, absolutely. So the doorways were stood up in 2019. The next sort of step in all of this planning and processes is that New Hampshire started to look at the launch of the rapid response system. So rapid response takes the way that the easiest way to kind of think about all of this is through that crisis now model that I was talking about in maybe that first background drivers slide. The crisis now model is national best practice in behavioral health crisis, system work. And it's essentially 3 pillars. And the first pillar is someone to call, and it could be call, text, or chat, but somebody to talk to. That's pillar number 1. The second pillar is someone to respond. And that's your mobile crisis teams, right? It's like having somebody be able to come and sit with you in the community if that's what's needed. And the third piece, the third pillar of an effective, robust, and sustainable crisis system is crisis stabilization, and that's more a 23-hour, say, like basically a less than 24-hour place that you could go that's sort of a living room model with peers and that kind of thing. So it's a step down from needing to be in a hospital emergency room and rather meeting people where they're at with a more of a community feel. So in New Hampshire, the rapid response system has started to stand up the first 2 of those 3 pillars. So pillar number 1, that's someone to call, somebody to talk to. That's that 24/7 centralized access point. It's phone, it's text, it's chat. They can do, phone triage, initial assessment, brief interventions, and deploy the mobile crisis teams. Pillar number 2, right? So the mobile crisis teams sit in all 10 of the community mental health centers and can be deployed throughout the state. Like with everything else that we've got going on across New Hampshire, there's workforce challenges, especially in different geographic regions. And so the idea that a mobile team will show up within an hour every time that's not necessarily always true. And that's something we're working really critically on quality improvement across the state and figuring out what are the best ways to deploy in rural regions, for example. But certainly all of the community mental health centers are in this, and the centralized access point knows how to deploy those teams. And if they're unable to come out, there's other opportunity to connect in your community. So that's the initial sort of location-based services and regional teams that can go out, as well as the statewide access point.
And Jenny, with that, my understanding is that if I were the caller, I would be informed of such. In other words, they would give an estimate of when I might be able to meet the crisis unit, or there would be an alternative expressed to me. Is that correct?
Yeah, of course. And the other thing is that I'll just say, near 80% of calls callers are de-escalated by phone, right? And so calling when we hear about, I wanted a mobile team, to deploy and it didn't work out, I just want to remind people that there's still a reason to be talking about it and making sure that we're that we're letting our citizens know that these resources exist, because 80% of the time the person is de-escalated by phone and then directly connected to follow-up services. And that's really critical to understand, even while at the same time we can say we've got to do some quality improvement, we've got to build workforce, to make the system what we envision it will be future state. But certainly it's already better than it was 2 years ago, right? Because there's a big, even when you're saying it's, if you're in crisis and we're saying we can be there within an hour, a couple of minutes feels like forever when you're in crisis. So an hour is actually, always going to feel too long, right? However, I think that we used to say, go to the ER and wait as long as it takes. So these improvements of meeting you where you're at and in that time frame, it is huge. And we're hearing that every day too from people in the community, what a difference some of these resources can really make to help you navigate through, sometimes the worst day of your life is when, that people are calling. The other thing is that opening it up to make sure that people can really call for any reason, and talking about calling for overwhelm and things like that mean that we have an opportunity to reach people and get them connected to resources well before a moment of crisis. And that's also huge for New Hampshire, right? Because we have talked about these previously as emergency services only. So this is a big change. Kara, do you want to jump in and kind of talk through what happens when you call?
Yeah,
talk a little bit more about rapid response?
absolutely. Yeah, thank you. Thanks, Jenny. So, I might reiterate some of the things that Jenny already said, but, prior to this, there are 10 regions of the state with 10 different community mental health centers. And I think it was confusing, what catchment area do I fall into? Where do I go? Who should I be calling? So developing that one centralized phone number, the 833-710-6477 phone number, was just huge. So the crisis line is staffed 24/7. You can call, you can text, or you can go to our website, nh988.com, and there's a chat feature there. Again, we don't define what a crisis is. My crisis is not going to be the same as your crisis. I hear so often in the community that people didn't call because they say they weren't feeling suicidal. And, we want you to call before it gets to that point. We want you to call when you're feeling overwhelmed, to talk through those issues. We have licensed clinicians on staff as well as clinically trained specialists. So, and that's what they do. They will attempt to de-escalate while also assessing the caller. They'll engage with them. They'll provide support. Sometimes we do a warm handoff to 211 if the person is talking through their issues and we find that they're having food insecurities or need housing assistance. We can do a warm handoff to 211 where they can pick up that call and continue to give those resources to the individual. Should the individual require additional levels of intervention, we have a software system where we're able to utilize our mobile crisis teams throughout the state. So we can go into the system, we can see where the individual is located, and we can see what teams are available. Prior to this, we couldn't do a lot of cross-region dispatch, but with this new system, we are able, if somebody's in Nashua and is having a crisis, but the Nashua teams are already meeting somebody else or they're not available, maybe we dispatch from Manchester or Concord. As Jenny said, we try to keep it within that 45 to an hour window. And especially North Country, we know that there are a lot of challenges up there. So their system looks a little bit different, and we use a lot of telehealth. So they're able to dispatch two peers that go out, and they'll telehealth in the licensed clinician to further assist the individual. And our teams will literally meet you where you are at. So if you don't want to meet at home, we can go to McDonald's, we can go to a park, we can go meet you at the Walmart parking lot. We really want, the individual to feel like they're being heard and that they're comfortable in that situation. If we are able to de-escalate the individual, but we do feel like a follow-up is required, we also have the ability to create urgent appointments with our community mental health centers for the individual. So they can be seen within the next 24 to 48 hours. It's not taking the place of an intake appointment, and it's not, I know that some of our CMHCs have wait lists, so it's not kind of jumping the line, but it is getting that person some additional care following their call to us. And then, as far as the follow-up goes, we have our own peer supports that will follow up with the people that have called in, just to ensure that they're still doing okay, that, their needs have been met, that they're still in a safe place. And just, we don't want to leave anybody hanging, right? We want to make sure that everybody feels supported and is followed up with. Jenny, did you have another slide? I feel like I talk a lot and then the slides catch up to me after.
Yeah, we just have like a what happens when I call. So if you want to
Yeah.
talk a little bit about that piece, I think that's helpful too.
Absolutely. We really try to talk through the issues. We do try to obtain some information from our callers. It is anonymous. You do not have to tell us, where you are or what your name is. Some people don't. We don't have geolocation, so we can't, ping your phone or find you in our system when you're calling. Obviously, if you're texting in, we have your phone number because that's how texting works. But if you don't want to give us information, you do not have to. We will make sure that, again, we're trying to de-escalate the situation. And if needed, then we can dispatch one of our mobile crisis teams out if they are available. Like Jenny said, unfortunately, sometimes teams are not available. And in those situations, we do have to ask the caller to utilize emergency services. And then the team will come out, excuse me, and continue the assessment within the community. They'll come up with a safety plan for the individual with their family, if the family is involved. And just, again, make sure that the person is safe and that they're being cared for in the community.
Kara, could I just ask a couple of questions here? Sometimes there's confusion about this long number in New Hampshire versus 988. So if you could maybe help everyone to understand the difference or what happens, or is there something
to go over that? That's next.
Yeah. Okay.
Yeah.
Great.
Yeah. Jenny's, you just queued that right up for her.
I had no idea.
Yeah, 988 is next. And so we'll be able to talk a little bit about, what this looks like. So in 2022, so we've got, 2019, New Hampshire stands up the doorways. 2021, New Hampshire launches rapid response. 2022, the National Suicide Prevention Lifeline transitioned from its 10-digit number to an easy to remember 3-digit number. So you all probably heard of the National Suicide Prevention Lifeline, right? And are probably used to the 273 talk number that you've seen, advertised. That on a federal level, there was legislation brought forward to actually transition that number to easy to remember number. There's research done about what should that look like. Is it 211? Is it a 311? Is it what does that look like? And how will that work? And the determination of the 988 number was based on what we had done as a nation with 911, and based on that information around learnings from launching 211 in many different states, and just trying to create something like the idea of we can call for police, fire, and ambulance. You call 911 for feeling overwhelmed and stressed and behavioral health crises of any kind. You call 988, right? So the difference really, Karen, to that question, the difference of 988 and rapid response is that 988 is national, right? And so it's a national resource, just like we have always had in the Suicide Prevention Lifeline. 988 is moving in the same direction as the way we talk about rapid response in New Hampshire, that it's across the lifespan, that it's substance use, that it's behavioral health, it's mental health, it's suicide prevention, it's all of those things. It's really just like call to get connected to resources and call, call early, call often, get upstream, call before you're in crisis, call while you're in crisis, right? And so that sort of expansion of how we define who can call and why you can call is right in line with what we're doing with rapid response. But with 988, it is still a national system. So Kara mentioned, geolocation services. The way that 911 works is that they actually have geolocation. And so they can find where the caller is located, right? And at this time, that FCC did not approve geolocation for 988. And some of that was based on advocacy from people with lived experience who said, we don't want you to send police and ambulance and fire to our homes. We want somewhere that we can call and talk to someone and know that emergency services aren't showing up against our will. And so there's still a really big national conversation around that, because it can be really helpful to deploy mobile teams to someone or to send emergency services to someone. But the idea is that the system is person-centered. And so the decision should be made with them. 988 is still a rescue line. So there are times that they will dispatch to someone, emergency services to someone's house. But that does happen less than 1% of their calls. And what has happened with the whole geolocation conversation is that may still happen. It may be that after they have a study committee all come together on that national level to talk about geolocation services, the FCC may approve them, and 988 may have geolocation similar to 911. Another thing that may happen is that they just may not approve them, and that it will continue routing in the way it is today, which I'll describe in just a minute. And the third option is that they may get geo-routing, and geo-routing is where they can like ping the nearest cell tower, but they don't know your exact location, but they are able to get you to your state, so that your state can say, here are resources around you, right? So the way that routing works right now for 988 is that when I call, I'm routed to the Lifeline Center based on my area code. So in my house, my husband and I are both working remote right now, right? And I have a Boston cell phone and he has an Arizona cell phone. So if we both were to call 988 from home in New Hampshire, I'm getting Massachusetts Lifeline and John is getting Arizona's Lifeline, right? Because we're being routed by our area code. If I am in a place where I am already de-escalated, I'm calling for resources, that Lifeline Center can transfer me to New Hampshire. But if I'm in immediate crisis, the protocol is not to transfer. It is to de-escalate the caller. That is the priority, right? So all the lifelines have each other's information, but transfers are not happening while a caller is escalated. Does that make sense?
Yes, and I love that point that you just said about everyone has everyone else's information. So it's like there's no wrong call, no wrong doorway per se. And I also like that it's emphasized here that that 3-digit number addresses mental health, substance use, and suicidal crisis. I think that's important for people to know too. So I appreciate you pointing that out.
So I think this is like, it's all positive because there's no wrong place to call when you're in crisis. The most important thing is that you call. So if you call a text or chat with 988, you're reaching a trained counselor on the other end of that line. That trained staff person is helping to de-escalate you by phone. If you're calling from a 603 area code, you're very likely to get either Headrest or Carillon, our 2 Lifeline centers located in New Hampshire. And if you get a New Hampshire center, you still have the same access to the dispatching of the mobile crisis teams. The confusing part is the routing part. So if you don't have a 603 area code, then that's the part where you may, like I said, I might be talking to Massachusetts or Arizona. I'm still getting the services of the de-escalation by phone, text, and chat, right? And then when I'm de-escalated, I can be connected back to my state. But the idea, if you feel as though you're calling for yourself or a family member, or you're calling as your business and you feel that a mobile crisis team is needed in your location, it's probably best to call the 833-710-6477 number, because you know you're getting Carillon every time, that rapid response, and you can get to that New Hampshire service. However, I find that for folks in crisis who want to remain anonymous, or are going to have trouble remembering a 10-digit number and all of that, 988 is an awesome option. I'm getting them all confused. See? And I'd say save them in your phone so you don't have to think about it, So this just, again, talk through all the things I already said. As a nation, we transitioned from a 10-digit number over to a 3-digit number. We expanded from just calls to calls, texts, and chat. So the different modalities. We expanded the serviceable population so that it's not very specific to the suicide prevention lifeline, but rather a crisis line more broadly. And people can call experiencing suicidal crises, mental health crises, substance use crises. And in New Hampshire, Headrest and Carillon are working really closely with 911, 211, the community mental health centers and the doorways and other service providers to make sure that you can get access to all of these different parts of our continuum of care. So I just put this up here because we are doing a ton of quality improvement, and all of these really big changes are a huge opportunity for New Hampshire to figure out how to get it right. And so, feel free if you have information about how a call has gone for you or your family or for your business when you're calling about an employee or any of that we have this email that's helping us understand what's going on in the community with our crisis transformation. And when we get those emails around that, we dig in really deep. I mean, we'll go to Carillon and say, on this date, this phone number called, and they will listen to the recording of that call. Or we will connect with the community mental health center and say, why were you unable to deploy? Was it a staffing issue? We'll get in the weeds because we're trying to build a system that's working.
Jenny, will the folks participating be able to have a copy of your slides?
Yeah, for sure.
Awesome, thanks.
So, this is just kind of thinking about what are the connections to your work, or if you have questions around any of this and recovery-friendly workplace, how can we help, right? So that's something I wanted to just talk to you all about and leave time to make sure we answer your questions. And then sort of the ways you can help is making sure we're sharing all these resources and we understand what they are and when and where to use them. And I'll leave it at that.
That's great, Jenny. Thanks so much. And with that, I'd like to give Melina Burton a little time to share a little bit more detail about New Hampshire 211. So Melina, I'm going to turn it right over to you, and then we will go into some questions.
Awesome. So we'll go ahead and pick this up. I apologize, my computer's slow. All right. Everybody see that?
Can see it. There we go. Yep, there you go.
All right.
You're just
So-
in like presenter view. So we're seeing it small with your note slides.
I don't know how to fix that.
Go to the 3 dots at the bottom, I think. And there you go.
You do slideshow from the beginning. Oh, I don't know.
No, if you go to the bottom and there's like a computer screen that looks like it's diagonally cut in half.
This one?
Yep. It's like display settings.
Now I got a black screen.
Or you could go to the 3 dots, and if it says display settings, it says hide presenter view.
There we go. Is that better?
Yeah, nice.
All right.
And now you might be able to go into slideshow mode, maybe again from the beginning. Try that.
All right, maybe we won't have.
Well, we can see it, okay. So if you want
All
to
right.
with that, it's fine. Melina, thank you.
You're welcome. All right, so I'm Melina. I'm the director of 211 New Hampshire. 211 is a resource line for anybody within the state. It is nationwide, so every state has their own 211. New Hampshire's 211 is special because we are the only 211 for the entire state, whereas other states have multiple 211s that cover their state. We have a database with over 4,000 different human service organizations that serve the state and offer assistance with a multitude of different things. So we are the state's homeless hotline. So anybody in the state who is suffering from homelessness can give 211 a call at any time. And we do a brief intake with them if they are willing. And that information goes into the homeless management information system, which is a federal database. And then we also send it to an outreach worker that serves their area so that they can be contacted and given other resources. We also give them, all of the shelters within the state, starting with the shelters that are closest to them to help assist them finding a bed. We are the access point for anyone with substance misuse for the doorways. We do a warm transfer. Like Jenny said, if they're calling and they're ready for help, the last thing we want to do is give them another phone number to call. So we do a warm transfer to the doorways to make sure that they're speaking to a clinician right then and there. We are a partner with Homeland Security and the Emergency Management and Disaster Recovery System for the state of New Hampshire. So anytime there's any kind of weather event, or that one time where the nuclear power plant in Seabrook, their alarms were sounding on the beach, everyone is told to call 211. That's where we help. We also manage the databases for ServiceLink. There are 13 different aging service agencies within the state that utilize those databases. We're the lead entity for people facing foreclosure in partnership with New Hampshire Housing Finance Authority. Anybody who is in a home and could be facing foreclosure can call 211 and do an intake, which then gets sent over to the New Hampshire Housing Finance Authority, and they can hopefully help keep them in their homes. And we are the access point. We just finished free tax season. We did over 11,000 tax calls this year for folks who are in need of free tax preparation. And then some of the other things that we help with, utility assistance is one of our top calls right now. That and rent assistance seem to be the things that people are suffering with the most in the state. But we also do food assistance, homeless shelters. When somebody calls, our operators ask for a zip code and age. A lot of people get their feathers ruffled when we ask for their age, but it's just because it narrows down in our database. We won't be giving them resources that they don't qualify for. So somebody who is 21 and is looking for help isn't going to qualify for ServiceLink unless they're disabled. So when we put in the age 21, ServiceLink doesn't even come up for us as an option for them, because we don't want to be giving them phone numbers that aren't going to help them, and then they're just running on this hamster wheel. So the zip code and age really narrows down what resources we give them so that they make less calls and they're able to get the help that they need sooner. This was our year end for this year. We did 73,588 calls throughout the entire year last year, and we had 46,000 visits to our website. Our top calls don't really, well, I shouldn't say that. Tax related calls are bump up to the top during tax season. But other than that, our top 5 calls usually don't change. It's substance, it's homeless, it's rent, and it's utilities are usually the popular ones. Our website, if they don't want to call 211, they want to try and get the resources on the website, they just click start searching now. They put in their zip code and their age and what it is that they're looking for help with, and it'll give them the same resources as if they were calling 211. And that's it. That's 211 in a nutshell.
That's great, Melina. Thanks so much. And we're actually in a perfect time frame. We have 5 or 6 minutes left for questions. So I'd like to open it up for questions, whether it be in the chat or if you want to unmute yourself and just or raise your hand and let us know if you have questions, because that was a lot of information to digest in one session. Christy, you can go ahead and stop the recording now too.